Assalamu alaikum. Now let's dive into PROM, premature rupture of the membrane, or preterm, pre-labor rupture of the membrane. Before jumping into this, just hear this. Can you guess the murmur? Okay, if you know, put it in the comment box. Okay, let's start. Preterm, pre-labor rupture of the membrane. Membrane rupture at less than 36 weeks of gestation prior to labor. Membrane rupture at less than 37 weeks of gestation prior to labor onset. Risk factor is prior pre-PROM, genitourinary infection, asymptomatic bacteria, bacterial vaginosis, preterm, pre-labor rupture of the membrane, asymptomatic bacteriuria, and antepartum bleeding. Diagnosis: vaginal pooling or fluid from cervix, vaginal uh, pooling or fluid from cervix, nitrogen positive fluid, nitrogen positive blue fluid, and finding on microscopy. If uh, if it is less than 34 weeks, latency antibiotic and corticosteroid. If it is less than 36 weeks, reassuring. If less than 36 weeks, non-reassuring delivery should be done. If it is more than 34 weeks, delivery should be done. So less than 34 weeks, reassuring, latency antibiotic and corticosteroid. Less than 34 weeks, non-reassuring delivery, and if it is more than 34 weeks, delivery. Complication is preterm labor, intra-amniotic infection, placental abruption, and umbilical cord prolapse. Placental abruption, preterm labor, placental abruption, infection. That's all. That's all about preterm pre-labor rupture of the membrane. Rupture of the membrane before onset of uterine contraction, and before 37 weeks. Management of preterm pre-labor rupture of the membrane. Management of preterm pre-labor rupture of the membrane. Rupture of the membrane less than 34 weeks. If it is uncomplicated, expected management latency, antibiotic corticosteroid, fetal surveillance, expected management latency, antibiotic like ampicillin and azithromycin, corticosteroid, and fetal surveillance. If there is infection less than 34 weeks with infection, fetal or maternal compromise, delivery intraamniotic antibiotic, ampicillin and azithromycin, corticosteroid, and magnesium sulfate if it is less than 32 weeks. If it is less than 32 weeks, if within 34 but less than 37 weeks, delivery. GVS prophylaxis, penicillin G with or without corticosteroid. Toccolytics is not indicated in PROM. It is only used to preterm labor if membrane have not been ruptured. If membrane is ruptured, why we're giving toccolytis? What is the role of doing uterine relaxation? What are the risk factors for premature and premature preterm rupture of the membrane? What are the risk factor of premature preterm rupture of the membrane? Ascending infection, group B streptococcus, smoking, multiple pregnancy and previous pre-prom. Although membrane rupture typically presents as sudden gush of fluid, presence can have subclinical presentation with slow leakage occurring over days with increased clear vaginal discharge. Okay, what is the likely diagnosis of an obese multiparous pregnant woman at 34 weeks of gestation? Presence with intermittent leakage of clear fluid and negative nitrogen or furnace. It may be stress in urinary incontinence as it is negative for test. So it is not the amniotic fluid that leaks out. It is stress urinary incontinence. A stress pool of urine into the a stress pool of urine into the posterior mm, in the posterior vagina may be seen on speculum examination because urine can become trapped in the vagina, retrograde vaginal voiding during pregnancy, differentiated from rupture membrane, negative nitrogen or furnace and absence of vaginal pooling, negative nitrogen or furnace and absence of vaginal pooling. If you look at here, this is nitrogen test. Fluid from the vaginal exam placed on this strip, fluid from vaginal strip. If this paper turns into blue, look at here. In here, paper turns into blue in the presence of alkaline pH. In here, pH is 7.5. Alkaline pH more than presence of alkaline amniotic fluid. So if paper turns into blue and pH is more than 7.1, in here pH is 7.5, looks like nitrogen test positive. This is the fern test. This is the fern test. Look at the ferning. Amniotic fluid, narrow fern versus cervical mucus, broad fern. In here, fluid from vaginal exam placed on a slide and allowed to dry. In here, fluid from vaginal examination placed on the slide and allowed to dry. If amniotic fluid, in here narrow fern. If it is cervical mucus fluid, is broad fern. Okay, so nitrogen test. It becomes blue in the presence of alkaline mucus, in the presence of alkaline amniotic fluid. And fern test, there is narrow fern and due to presence of amniotic fluid. Now chorioamnionitis like intraamniotic infection. First we read these preterm prelabor rupture of the membrane. Now chorioamnionitis, intraamniotic infection. Chorioamnionitis or intraamniotic prolonged rupture of the membrane more than 18 hours. Prolonged rupture of the membrane more than 18 hours. Preterm prelabor rupture of the membrane and prolonged labor. So prolonged rupture of the membrane more than 18 hours, preterm, pre-labor rupture of the membrane and prolonged labor, repetitive vaginal examination, presence of genital tract pathogens and internal fetal or uterine monitoring device. The most high part of these boxes is this. How to diagnose if there is maternal fever with one of the features, like fetal tachycardia, like maternal leukocytosis, and purulent amniotic fluid. Fit, Maternal fever plus one of the following, like fetal tachycardia, purulent amniotic fluid, and maternal leukocytosis. If it is present, then it is chorioamnionitis. Management is broad spectrum antibiotics and delivery. Complication maternal is PPH, endometritis, and preterm birth, pneumonia, and encephalopathy. Deliver regardless of age. A low amniotic fluid glucose is an indicator. Of intra-amniotic fluid infection. Low amniotic fluid glucose means somebody, this infection is taking the glucose. That's why there is fluid low amniotic fluid glucose. Management is IV ampicillin and gentamicin with or without clindamycin. Intermittent immediate delivery by augmentation of the liver. CS generally not indicated unless obstetrical complication like non-reassuring tracing, breech presentation. What is the next step in the management for pregnant women at 38 weeks of gestation with chorioamnionitis after administration of the antibiotic? Fetal heart rate tracing reveals tachycardia and otherwise reassuring. So you should do induction of the liver. Cesarean delivery is reserved for standard obstetric indication like prior uterine surgeries, breech presentation, non-reassuring fetal heart rate. Saying what is the likely diagnosis of an intrapartum patient that presents more than 18 hours of the membrane? that presents more than 18 hours of the membrane rupture and a prolonged labor with fever and tachycardia. Fetal heart rate tracing demonstrate fetal tachycardia. It is chorioamnionitis infection. So maternal fever plus one of the feature fetal tachycardia, maternal leukocytosis, fetal tachycardia, maternal leukocytosis, and purulent amniotic fluid. Purulent amniotic fluid. So intraamniotic infection caused by migration of the vaginal or enteric flora through the cervix, typically in a patient with premature or prolonged rupture of the membrane, and intrapartum fever is a distinguishing feature. Okay, now some questions. Now start with this question. This 23-year-old man gravid to Paravan 30 weeks of gestation due to sudden gush of clear vaginal fluid. Sudden gush of clear vaginal fluid. Okay, 30 weeks of gestation. Nitrogen positive. So looks like amniotic fluid. A vaginal pooling of a nitrogen positive clear fluid. Ultrasound shows a fetus in a breech presentation, and there is decreased amniotic fluid. Which of the following is the next step in the management? 30 weeks of gestation. So APTM, 30 weeks of gestation APTM. That means antenatal corticosteroid, penicillin FGBS, tocolytics, and Maxsulf can be given. But in here, if as it is less than 34 weeks, this is preterm, pre-labor rupture of the membrane. This is preterm, pre-labor rupture of the membrane. Usually that was the expected management, but in here, as it is preterm, pre-labor rupture of the membrane, less than 30 weeks, so less than 34 weeks, as it is nitrogen test is positive, so we should give latency antibiotic, we should do expected management, we can give corticosteroid and fetal surveillance. We can do fetal surveillance. In here, delivery is not, because there is no infection or maternal compromise is seen on the stem. So patient who have an uncomplicated preterm pre-labor rupture of the membrane less than 34 weeks of gestation and manage expectantly with antibiotics, corticosteroid to promote the utero development, and delivery is indicated if these signs of intraamniotic infection and deteriorating fetal or maternal status, or has reached if the pregnancy has reached the 34 weeks of gestation. So it looks like we should do preterm pre-labor rupture of the preterm pre-labor rupture of the membrane. Okay, now look at this question. In here, 39 weeks of gestation. Okay, the nausea began and last night and has progressively worsened. Okay, the patient was treated with chlamydia. Okay, nitrogen positive, clear fluid, nitrogen positive. So there is amniotic fluid leaking. The cervix is 2 centimeter dilated. Cervix is 2 centimeter dilated, and fetal heart rate is slightly higher, 165 per minute. Moderate variability, no deceleration. Looks like, uh, and the leukocyte is higher. So in here, the most important maternal fever 103. Maternal fever with a fetal a maternal fever with leukocytosis, maternal fever with leukocytosis. So if two criteria met, and if there is fetal heart rate is higher, so if these criteria is met, it is chorioamnionitis. So intraamniotic infection or chorioamnionitis, the most common complication in preterm pre-labor rupture of the membrane in those with prolonged rupture of the membrane more than 18 hours if there is prolonged rupture of the membrane 18 hours, and if there is preterm pre-labor rupture of the membrane, in maternal fever with fetal tachycardia, maternal leukocytosis, maternal leukocyte count is more than 18,000, and there is fetal tachycardia, and there may be maternal tachycardia. If these symptoms met, then it is called as chorioamnionitis. So it is chorioamnionitis. What should we do in addition to broad spectrum antibiotic? What should the best next step? In chorioamnionitis, the next best step is a labor augmentation. Labor augmentation should be done. So we diagnose via these feature maternal fever plus one of the fetal tachycardia or maternal leukocytosis or pool and amniotic fluid. If these criteria met, so it is intraamniotic infection. So treatment is immediate delivery. That is important. Immediate delivery by augmentation of the liver to remove the source of augmentation of the liver to remove the source of infection. So you need to remember this. You need to remember this. So this is a pattern where we should diagnose and treat maternal chorioamnionitis. Okay, if you look at this uh, picture, what is the most likely contributed to this patient presentation? 26 weeks of gestation for evaluation of increased vaginal discharge. Okay, these and that. Okay, speculum examination. Okay, there is clear nitrogen positive fluid in the vagina and the cervix is closed. So as in amniotic fluid there is nitrogen positive fluid in the vagina. So looks like it is leakage of the amniotic fluid. Fetal heart rate tracing is 150. Mm, okay. There is irregular contraction of the tocodynamometry. What is and transabdominal ultrasound show anterior placenta and an amniotic fluid index is 3 centimeter. What is the most likely contributed presentation? It may be asymptomatic bacteria. One of the feature like genitourinary infection and asymptomatic bacteria can cause preterm, pre-labor rupture of the membrane. So asymptomatic bacteria prior PROM, asymptomatic bacteria prior PROM, and and genitourinary infection. So 26 weeks pool of nitrogen fluid, closed cervix consistent with uh, closed cervix, nitrogen positive, consistent with preterm pre-labor rupture of the membrane. Risk factor is prior pre-prom condition, over distance polyhydramnios and condition that inflame or weaken the membranes such as antepartum bleeding, genital infection, bacterial vaginosis, gonorrhea, and asymptomatic bacteriuria like group B streptococcus, asymptomatic bacteriuria, or bacterial vaginosis. These are the things can cause preterm pre-labor rupture of the membrane. Preterm pre-labor. If you look at this question, if we look at this question, in here it is 29 weeks of gestation. Okay, what complication can happen? If we look at this, like speculum shows microscopy, there is farning positive. Farning, the microscopy show narrow farning or farning with squamous epithelial cell with no stippling. That means pregnancy test is positive. As farning is positive, that means there is leakage of the amniotic fluid. As there is leakage of the amniotic fluid, so it's look like preterm labor, and the complication can happen in preterm labor, preterm pre-labor rupture of the membrane, preterm pre-labor rupture of the membrane. Like complication is preterm labor, intraamniotic infection, placental abruption. This is IL, placental abruption, and umbilical cord prolapse. Placental abruption and umbilical cord prolapse. Okay, now if you look at this question in here, there is speculum show closed cervix fluid farning is noted on microscopy. As farning is noted on the microscopy, looks like amniotic fluid leakage. That means It is preterm pre-labor rupture of the membrane, preterm pre-labor, as the weeks is less than 34 weeks. Expected management, latency antibiotic and corticosteroid. Upper expected management, antibiotic, ampicillin, azithromycin, corticosteroid, and fetal surveillance. Fetal surveillance should be done. Fetal surveillance should be done. Okay, now next question. In here, again, nitrogen positive, nitrogen paper becomes blue, so looks like preterm pre-labor rupture of the membrane. Preterm pre-labor rupture of the membrane. So a patient fetal heart rate is higher, there is maternal fever, fetal heart rate is higher, maybe maternal leukocytosis, nitrogen positive, nitrogen becomes blue, amniotic fluid index. So immediate induction of the liver, intraamniotic infection, 26 weeks, preterm pre-liver rupture of the membrane, leakage. So immediate induction. In here delivery is done via induction, not via cesarean section. Cesarean section can be done if the patient has other issues like if there is cervical problem, cervical insufficiency, and other problems, or then like absolute contraindication of the delivery, then we can do the cesarean section. These the final question, this question, look at 10 weeks of gestation, only 10 weeks of gestation. Okay, abdomen, pelvic ultrasound, intrauterine pregnancy, 10-week, hemoglobin, there is increased risk of which uh, pre this patient 10 weeks of gestation comes to the initial prenatal visit. She was not expecting this pregnancy because she had uncomplicated term vaginal delivery 6 months ago and breastfed for the 4 months of postpartum. She's taking daily prenatal, so she has chances of uh, preterm pre-labor rupture of the membrane. This is very high yield. If there is short interpregnancy interval can cause preterm pre-labor rupture of the membrane. Uh, less than 6 to 18 months from delivery to less than 6 to 18 months, less than 6 to 18 months from delivery to next pregnancy, maternal anemia, pre-prom, preterm delivery, low birth weight. These can happen. So short interval of pregnancy, one of the high yield complication, uh, it can cause preterm pre-labor rupture of the membrane. If you know the murmur, put it in the comment box, and if you like my video, please give comment and share. Hope you enjoy.